This is Cesar with Nursing School Made Easy. This lecture is focusing on number 1, osteoarthritis, and the second video is going to focus on rheumatoid arthritis. So let's get right into it. Again, osteoarthritis is a result of cartilage damage. Now, a big thing to remember with osteoarthritis is that inflammation is typically not a characteristic of osteoarthritis. Again, inflammation is not a characteristic of osteoarthritis. Pain usually results from a contact between exposed bony surfaces after cartilage destruction. So what does that mean? Let's pretend that this is the knee joint here. My drawing's not very good, actually. Let's do something different because that's too big for our camera here. Say this is the femur. Femur is going to be surrounded, or the lower portion is going to be surrounded by cartilage. You can think of cartilage as a cushion. It's going to help absorb impact. Right below that you would have your tib fib. Okay, this would make up the knee joint. So this cartilage here is going to help, again, cushion. It's going to help absorb impact so that when you bend your knee, you feel no pain. Well, in osteoarthritis, we just talked about how osteoarthritis is, again, damage or deterioration of the cartilage. So what will end up happening is on that same bone, give me a femur, instead of having that thick layer of cartilage, now you have decreased joint space. What you'll almost end up having is bone on bone contact. Anytime you bend, or anytime you walk, anytime you stand, all this weight is causing the femur to come into contact with the tib fib, and that is what would cause pain, because again you have deterioration of this cartilage layer. So now what would some signs and symptoms be? Number 1, discomfort. 2, joint pain. Now, one thing to remember here for your NCLEX exam is that pain worsens with joint use. So you may tell the patient to rest for pain relief. The other thing to remember is that pain may increase with temperature changes, especially during the cold. 3, the decrease in cartilage will lead to crepitation or a grinding feeling. This is especially present in, for example, again, the knee joint. Anytime the patient bends and sits up or stands again, they will feel a grinding. Again, that is crepitation, and again, that is due to that decreased amount of cartilage in the joint. Now, this crepitation is present in about 90% of patients with knee osteoarthritis. So again, anybody with knee problems, just tell them to put their hand on their knee, sit down or bend their knee and stand up or extend their knee, and they most likely will feel a grinding sensation. Now let's talk about joints that are affected. Typically the joints that are affected by osteoarthritis are weight-bearing joints. This would include knee, shoulders, cervical and L spine, hips, and also your fingers and hands and feet. Now, because of the decrease in joint space and decreased cartilage in that joint space, you may have some joint malalignment. And because of the joint malalignment, the discomfort and the pain, you will have altered gait. So the patient may walk a little funny. So pay attention to how they walk. Is one leg shorter than the other? Okay, that may be due again to the decreased joint space, especially if there's decreased joint space in, for example, the knee and the hip. That would again cause some shortening there. Now let's focus on some diagnostic studies. Typically what would be done first is an x-ray. Just a simple plain x-ray. An x-ray would be able to tell you whether there's decreased joint space or not. They want to get more specific, maybe something like a CT or MRI would be done. But the first thing that would most likely be done would be a just plain x-ray. Number 2, ESR, and know this for the NCLEX. Now ESR is erythrocyte sedimentation rate. Now this may be elevated only during acute inflammation. Okay? So again, this will be elevated during acute synovitis or acute inflammation of the joint space cartilage. Okay, so remember this ESR. Interventions. What would you do for your patient? As always, make sure you focus and you know your signs and symptoms and your interventions, because that's what the NCLEX is going to test you on whether you know what to do for your patient. So number 1, you would tell your patient to rest. Number 2, we talked about how there would be some malalignment due to, again, that decrease in joint space and to that deterioration of that cartilage. So you would tell that patient to do some splinting or maybe use a brace. I've seen a lot of athletes use knee braces. Again, there's a lot of weight on those knees, so they might again use a brace to help support the knee a little bit better. Now remember to tell your patient to try to get some rest, again to use a splint or brace, but to definitely not immobilize whatever area for longer than a week. You do that and you're going to cause some joint stiffness. So again, make sure that you do perform some immobilization, but that immobilization should not exceed 1 week. Number 3, you should avoid prolonged standing, kneeling, or squatting, pretty much anything that's going to aggravate the pain. Number 4, you can use heat and ice. 5, weight loss. Now again, the intervention will be determined by what the patient is doing or what type of patient it is. For example, if it's an athlete that is doing a lot of bench press, a lot of squatting, well then you would tell them to cut back on the bench press, on the squatting, on the running, on that activity. You would tell them to get a little bit of rest. Now, if it's, for example, somebody who is obese is extremely heavy, well then they would benefit from some weight loss. And in that type of patient, you would encourage physical activity so that again weight loss would occur. If you have weight loss, that would mean decreased weight on those weight-bearing joints. Now, 6, medications. So you could give something like acetaminophen or Tylenol. You can use NSAIDs like ibuprofen. Now remember that with the NSAIDs, you might run into some GI tract problems, maybe some GI bleeding, ulcer development if again the NSAID use is prolonged. So you would also have to educate your patient on the side effects of NSAIDs. Now patients may also use something like aspirin, but you would caution your patient not to take NSAIDs and aspirin because this would cause problems with your platelets and your clotting time would increase, so that would put a patient at higher risk for bleeding out. Number 8, the Cox inhibitors, COX-2 inhibitors, something like Celebrex, can also be used. And number 9 that we talked about a little bit ago was aspirin, and again you would tell them not to combine or take aspirin with NSAIDs because again due to the effects on the platelets and increasing clotting time.